have to fight with me, so there we go. Thank you all for staying. I'd like to say it's just been an absolute pleasure to be here. It's been a wonderful 2 days, and great to meet up with some old friends and also make lots of new friends. So thank you for having me. So the last thing we'll talk about, we hinted about it a little bit in the previous patella talks, is just a little bit about trochleoplasty. And I know this is a very hot topic some places, and it also causes a lot of fights, so it's a good thing I'm the only one up here. So I'll just try to give you an overview of trochlear dysplasia and how it can influence our surgery. So first, I think it's really important to understand why we would correct high-grade dysplasia. Like, who cares? Who cares they don't have a groove? Why does it matter? Well, first of all, no matter what you hear around the world, the trochleoplasty is not an evil operation. And this is a bit like patellar tendons. People get very passionate about trochleoplasty, but it is not an evil operation. It is also not going to be a common operation you do, so you want to pick a couple of people in your region that may understand it and be good at it, but not every knee surgeon will be doing many trochleoplasties. I do about, I would say, 20 a year. I think if you talk to David DeJour in Lyon, he does 20 a year. So these are you have the trochleoplasties come to the surgeons that see lots of this. But there's a reason we don't like high-grade dysplasia. So if you have a patella balancing on a mountain top, there is a lot of force on that graph. So you have lost all your bony support for your patella, and if you're going to reconstruct an MPFL, there's just going to be more force on that graft for the patella to redislocate than if they don't have dysplasia. So it's the same thing for an ACL. If you have no medial meniscus, there's more force on your ACL graft. If you have high-grade dysplasia, there's going to be more force on your MPFL graft. So it's not scary or weird, it's just more forces, and we have to create a graft when we reconstruct things that will withstand the forces that we demand of it. It also leads to poor tracking. So we talked about the J sign yesterday. If you don't have a nice groove, you'll have poor tracking, which again puts more force on your graft and can cause that symptomatic J sign. And then the thing people don't talk about much is that if you have high-grade dysplasia, you will eventually get patellofemoral arthritis. So we know that if you balance a football on a soccer ball, rugby ball on a rugby ball, you increase the forces, and so you get overload of the patellofemoral joint, and patients with high-grade dysplasia almost for sure go on to patellofemoral arthritis down the road. So trochleoplasty is not a scary procedure. In fact, there's a lot of data out there, and there's even systematic reviews reviewing trochleoplasty procedures, and this slide is even a little bit older. So already there's more than 1,000 patients that have been described that have had a trochleoplasty with almost 20-year follow-up. So this is not a new operation, and we have good long-term follow-up, and all of the studies show that there is good clinical outcomes, there's a low redislocation rate, and a relatively low complication rate in something that is actually quite a big procedure. So we have good data on outcomes after trochleoplasty, and we have long-term data on outcomes after trochleoplasty. And there's some of the papers, you don't need to see those. But really, when you look at MPFL reconstruction, what causes failure? So Petri Salanpa, a very famous patellofemoral surgeon in Tampere in Finland, he and I got together, and we both have quite a big series of young patients with MPFL reconstruction. And we pooled all our patients. So we had almost 600 patients who had done MPFL reconstruction, and we looked at all the failures. So out of that, 29 failures. So that's about the literature rate, 5% failure for MPFL reconstruction. And the biggest cause for failure of an MPFL reconstruction was high-grade dysplasia. And you could see 65% of the patients that failed had high-grade dysplasia. And in half of the patients, we felt that when you looked at the whole patient, that was the most responsible reason for the failure. And so, as quite rightly, we corrected that pathoanatomy, and 12 had trochleoplasty as part of their revision. So trochleoplasty is important and it is needed. It's just needed in a specific patient population, and that's the part that we need to understand. Failure is not our only outcome, however. So we have patient-reported outcomes, we have pain, there's lots of different outcomes. Failure is just one of them. If failure was your only outcome for a shoulder instability operation, I could just fuse everybody's shoulder and they'd never dislocate again, and I would have a perfect outcome. So clearly failure is not the only outcome. And there's multiple studies that have been done and are ongoing looking at outcome, and they all show that even without failure in the mix, that clinical outcomes are worse in patients that have trochlear dysplasia. So their quality of life scores are lower, their Kujala scores are lower, pain scores, satisfaction lower. So we know that trochlear dysplasia is a problem, both for outcomes and for failure. So then you say, okay, Lori, when do we address it? When do we actually start thinking about doing a trochleoplasty? Well, we looked at 200 patients, so some of these were the same patients in the other study, and we looked at them 2 years post-operative with our BPI score, and it's a patient-reported quality of life, disease-specific outcome measure. And then we compared the low-grade dysplasias to the high-grade dysplasia. And what we found is that you could correlate that amount of dysplasia to their BPI scores, and what we saw was a trochlear bump greater than 5 millimeters contributed to lower quality of life scores. So we're starting to tell the story that we have failure, we have poorer outcomes, and now we even have some numbers on it. A bump about 5 millimeters or greater, those are your bad actors. So that begs the question, what is the trochlear bump? And you would think that this would be easy to see on imaging and easy to classify, but I find there's a lot of confusion about what we call a trochlear bump. They can't even, they as us, can't even decide what to call it. So some people call it a trochlear bump, some people call it a supratrochlear spur. There's a bunch of different names for it, so we can't even agree on what to call this thing. So I want to try to give you some examples. So the most famous classification is out of Lyon, David Dujour classified trochlear dysplasia A, B, C, D. So you'll see this nice picture in all your textbooks and all your papers and talks about trochlear dysplasia. The problem is that not all trochlear dysplasia falls into these categories. There's other categories in there. It's very different in every single patient. So when you look at the inter-observer reliability of Dujour classification, it's actually not very good. So that means when even high-volume MPFL surgeons are talking to each other, they're not always talking about the same thing. What I think is a Dujour type D, Guillermo might think is a Dujour type B, and so it's really hard to discuss who you're going to operate on and how you're going to follow people if we can't agree on that. So most people have started to talk about low-grade dysplasia versus high-grade dysplasia, but anytime you split things into two classifications, of course, there's big, broad implications for that. I like to talk about low and high grade and then talk about the bump, because it's really that trochlear bump that gives you all your decision-making power if you're looking at thinking about a trochleoplasty. So, what's the bump? All right, so, where's my pointy? So, here's a patient with low-grade dysplasia. So, I like to look at these the best on plain x-rays. So when you look at a plain x-ray, number one, you must have a true lateral. And sometimes you have to send the patients back to the x-ray to get a true lateral. If you've got a true lateral, you draw a line on the anterior border of the femur. Why are all mine on timings? Okay, and then you draw a line on the base of the trochlear groove. These two lines do not intersect. This patient has low to no dysplasia, low grade to no dysplasia. Okay, this is the view from the supralateral portal. You see the base of the trochlear groove is pretty even with the anterior border of the femur. There's not a big ledge there. Here's a patient with high-grade dysplasia, okay? True lateral x-ray. We're going to draw that line, right? Now I'm going to draw the base of the trochlear groove. Do you see how this base of the trochlear groove extends anterior to the anterior border of the femur? It's not supposed to do that. That means that all this bone here, all that area of bone, which is actually volume, right, because it's in 3 dimensions, all of that is your trochlear bump. I don't like calling it a spur because a spur implies something's pulling on it, right? That makes it come. This is a bump. This bone is not supposed to be there, so the patella has to jump over that to reach into the groove that exists lower down into flexion. Here's that same view from the supralateral portal. Look at the distance between the base of the trochlear groove to the anterior abortive femur. This is probably an 8 mm bump. I don't have my probe in that one, but so the patella has to get up into there before it can enter the groove. So this is where I like to look at a good lateral x-ray, and to me, I can almost tell right away if someone needs a trochleoplasty or it would be a candidate by looking at that amount of bone that extends anterior to the femur. So when you look at trochlear dysplasia, if you look at David Dejour's literature, in France, they must have a lot of family history. So 96% of patients have a family history of patellar instability. In Canada, that's not true at all. Almost no family history in Canada. So there's many regional variations, so you have to figure out how it works here. But we know that trochlear dysplasia is a risk factor. So I've told you a bunch of clinical outcomes that shows that trochlear dysplasia is a problem, but there's a whole bunch of biomechanical studies, many of them done in London in Andrew Amos's lab using their little robot, and they all show that trochlear dysplasia causes increased forces on that graft. So it's not just the clinical studies, it's also the biomechanical studies. So when then are we going to address trochlear dysplasia? We now know how to identify it. We know that it's bad. When are we going to address it? Well, we know that it's worse outcomes. And so as soon as there's a trochlear bump, so if we have high-grade dysplasia and the trochlear bump is greater than 5, we know that's going to be bad. And remember our J-sign talk? Maybe this should have been right before this, but that J-sign, if they have that hard J-sign, you cannot believe that any soft tissue graft that's as big as a gracilis will hold a hard J-sign patella in the groove. So we know if they have that jumping J-sign or that hard J-sign, we know we need to do something bony, and if they have high-grade dysplasia, that's what we should be addressing. And then again, my criteria for addressing the trochlear dysplasia will go down if they've already failed an MPFL, because I know they already can't tolerate the forces on their graft. So maybe my criteria goes a little bit easier. So what are the principles of trochleoplasty? And this is the questions I get where, they have some femoral anteversion, they have trochlear dysplasia. Do you do a TTO? Do you do a derotation osteotomy? But the principles of fixing a patella and stabilizing a patella are you want to fix the bony pathoanatomy at the site of deformity. So when we all did residency, we all learned about Dror Paley and all his science stuff that I barely understood. But we always want to fix at the site of the deformity. It's one of the basic principles of orthopedics. So then I ask you, if you have trochlear dysplasia, why would you do a TTO to help fix the trochlear dysplasia? That's not where the deformity is. If it's a big arthritic knee and you're doing something not at the site of deformity on purpose, because that's what you choose to do, that's fine. But in a young patient, we want to fix them as close to normal as possible. So if the deformity is at the trochlea, we should be fixing at the trochlea. Basic orthopedic principles. I'm going to show you a little video. I made it short, don't worry. So I use an anterolateral approach. So if you need a trochleoplasty, you also need a lateral retinacular lengthening. Because if you are in the groove and you don't need that lateral lengthened, you probably don't need the trochleoplasty. So I use an anterolateral approach and I lengthen the retinaculum on the way in. I come in from superior, so the head of the patient is up here. I come in from superior with a curved osteotome. We lift a 3 to 5 millimeter osteochondral flap. It takes a little longer than this, I promise. And then I use a burr. So this is a high-speed burr. There's a Lindemann attachment that's like a drill, but it has also side cutting, so I can use that to go deeper and more distal in my osteochondral flap. And then I use an oval burr to dig out the groove. So we go back and forth. This is a bit of a modified one. This patient's dysplasia was very proximal, so I didn't have to lift the osteochondral flap all the way down to the notch. I call this a modified trochleoplasty, just a little bit smaller and a little less risky. So we clear a new groove in the bone, and then we thin that flap of bone until it's malleable. So I use the oval drill, or the oval burr, to thin the flap. So we lift a flap, we dig a groove, we thin the flap, and then we push the flap into our new groove. There's multiple ways to fix this. Most of the Europeans use Vicryl tapes. Those are not available in Canada for some very weird reason. So I use this as a smart nail. So it's a little bioabsorbable tack that has compressive capabilities, so it compresses in. And this is very, very easy to do open because it's actually made to do arthroscopic. So it's very easy to do open. And it's meant to fix osteochondral fractures. So this is a created osteochondral fracture, and there's our new groove. So again, we've protected our cartilage, we keep it moist, we've done our lateral lengthening, and there you can see we've created a nice new groove. And I don't think you need to create a perfect groove, you need to create a low-grade dysplasia. So if you're going to do an MPFL reconstruction and you give the patient low-grade dysplasia, so at least it goes this way instead of this way, then I think you've done them a good favor and you've improved those biomechanics. So, a couple final thoughts. Outcome measures. Very, very important. Most of the literature will tell you the Kujala score. The Kujala score is not meant for patellar instability. It was an anterior knee pain score. So everybody has a good Kujala after you do anything to them. So it's not a very good measure. We want disease-specific, patient-reported quality of life outcome measures. But we also want to think about things like what we just talked about with the ACL. Patella patients, even more than ACL patients, have very big issues with pain catastrophizing and kinesiophobia. So we're doing some research on this right now, but I can tell you that of all the knee patients, so arthroplasty, meniscal tears, osteochondral lesions, patella patients have the worst of these kind of scores. And then using virtual reality, which we talked about earlier, to try to practice some of these things and teach some of these procedures that we don't do very often. So those are the things that I think are in the future. There's also some new models coming out. This is another friend, my friends have a lot of companies. This is a company out of Calgary, and he's created a new kind of knee model. It's like a sawbones, but even with his skin and everything else. And this is our old fellow and my partner, and we were teaching him how to do a trochleoplasty during his fellowship. So there's a lot that we can look forward to in the future as we learn more and more about this. And hopefully we can get some pre-op planning in there, especially with patient-specific imaging in the VR. So trochleoplasty is technically demanding. You want to practice this, you want to see a bunch, you want to go visit someone who knows how to do them so you can learn. You also want to decide you're the one that wants to be doing these. These are difficult patients, it's a big surgery, it's a lot of decision making. So I think for most knee surgeons, just being able to identify that the patient might need to be considered and pooling those into a central intake area, someone who sees a lot of complex patients would be a really good idea. And really we need to do the research and keep looking at these things because it's a very fun topic. So thank you.
Bueno, ya hemos llegado al final de la parte educativa. Realmente un placer haberlos tenido a ustedes, un placer tenerlos los expositores de tan alto nivel y que se han ceñido muy bien a los tiempos y hemos logrado completar la jornada con la puntualidad que siempre nos caracteriza en estos eventos. No queremos dejar de agradecer a todas las personas involucradas, a las empresas que han apostado y han querido apoyar este evento educativo, a todo el grupo que tanto de servicio de organización como lo que nos apoyan en lo que es el audio y la visión. Queremos sobre todo agradecer a las ganas de todos nosotros de querer siempre superarnos, de querer ser mejores. Así que les dejo al doctor Rolando Suárez, organizador del evento, para dar las palabras finales.
Antes de irnos, agradezco a todos los profesores, a los asistentes, a las casas comerciales y gracias Miriam por estar otra vez con nosotros. Nos vemos dentro de 2 años. Gracias.